Good morning, everybody. Thank you very much for coming to this special session this early, bright morning on Ebola. I'm Dr. Sai Haranath. I'm the chair of the Disaster Response Network. I come from Hyderabad, India. I would like to welcome Dr. Lewis Rubinson and Dr. Mike Connor to give their presentations today. The story of Ebola has primarily been a story of compassion, confusion, and critical care, but mostly about compassion. I think we need to give it to these gentlemen who have actually taken care of patients with Ebola and have done an extreme amount of service to this whole country and the world by actually going to the front lines and actually taking care of these patients. I think we would love to hear from Dr. Rubinson first, who is from the Shock Trauma Center. If you Google his name, you're going to see that he actually was on NPR not too long ago, and he would actually like to talk to us about clinical care of patients in Sierra Leone with Ebola, followed by Dr. Connor, who's a nephrologist and a critical care specialist from Emory University, and he'll be telling us about how he took care of patients at their university. We are short on time, so we're going to be going to the presentations first, and then if we have time right after, we'll go through a bunch of questions. Thank you very much, and thank you for coming again.
Thank you, Sai. Can everyone hear me? I'm going to step down here so I don't fall off the stage. So I'm going to take you through a whirlwind tour of Sierra Leone, and then Mike is going to take us through the experience at Emory. Just for disclaimers and disclosures, the one I want to point out is really the one at the bottom. So I went as part of a WHO team to Sierra Leone in September. I noticed people are still giving me distance, so you can come a little bit closer. I did finish my quarantine, but just it's important to note, even though I was a WHO consultant, this talk does not represent any opinions or any policy from the WHO. So the objectives, I'm going to give a very quick, cursory, kind of broad-based, but not really drill down too deep, which is really the experience in West Africa itself in clinical care, to talk about the patients, and then Mike is going to be able to drill down much deeper to give a lot of the science from their experience in Emory. I'm going to talk a little bit about how dangerous Ebola is and isn't. Unfortunately, given just the time constraints, because we've been modifying the talks to fit into the schedule here, I'm not going to be able to talk about the realities of clinical care. I did want to talk to people about what it's like to go out there, and if you're thinking about going out there, how to choose the proper organization, how to be safe, but I'd be glad to talk with folks offline about that. And then lastly, I'm going to talk about really what did we learn from West Africa to be able to translate to make U.S. hospitals more prepared. So where is Sierra Leone? Remember here, West Africa, it's on the tip. It's one of 3 very small countries. Right there we have Liberia, Guinea, and Sierra Leone that are most impacted. Nigeria did have an outbreak, and Senegal had a small outbreak as well. Senegal and Nigeria have been able to be contained. In terms of just geography for Sierra Leone, the capital is right there, Freetown, and that's where the game is right now. There's about 1.5 million people in Freetown, and the disease is pretty rampant. It's also rampant in Port Loko. When disease came down from Guinea, it actually came down from the east near Kailahun, and that's where the first treatment center was set up by Doctors Without Borders. I'll talk to you about my experience at KENEMA Government Hospital, which is down here. And now really you're seeing cases throughout, but most of the game is on the western side of the country. Sierra Leone had a long amount of civil war. They were really just starting to recover. It takes about a decade to come out of that to really start growing. So unfortunately, this outbreak has really hit a community that's going to be struggle to be able to respond because the infrastructures were just starting to grow. It's a very young country in terms of people, given their experience with war, and then also the way the birth rates work. In addition, it's a very poor country. So the GDP is probably less than what George Soros makes in a year for one person, and that's the entire country's GDP. Oops. And the baseline, you can imagine when disease spreads in West Africa, it's very, very hard to control. There's a tremendous amount of poverty. Most of the cities are actually city slums. So people are very close together. The commerce is dependent on that. The transportation is dependent on people being very close together, and disease can spread like wildfire. So the pillars of Ebola control are not too dissimilar to other disease control. Very important to find the cases and to figure out who they've been around, especially those who've had true exposures to body fluids. You have to isolate them out of the community to be able to stop spread. The clinical care is very important, and that's the aspect that I played. And the reason why is you need to give people a sense that there's actually a survival basis for coming out of their communities and going into treatment centers. If Ebola is invariably deadly, folks are not going to be encouraged to be able to come out and report. And then lastly, the safe treatment of the dead cannot be understated. That is where most of the spread was happening early on. So when I got to KENEMA, which again is in the middle of the country, the disease had really taken hold on the eastern side, and by then Bombali, McKinney, and other areas were starting to be on fire. But KENEMA Government Hospital, even though in our district alone we weren't seeing as many cases because the disease had already spread from east to west, this really was the referral center for all of the country. So originally KENEMA Government Hospital had the only dedicated Lassa ward in the world. Fortunately, when I was there, Lassa had not taken hold yet. Lassa is just about to come online now as harvest happens and as grain is brought into the house. That's where the rodents come into the house and will spread Lassa. So that's going to make the next few months in Sierra Leone very difficult to manage because of the overlap of symptoms between Lassa and Ebola. The treatment centers were really minimal. There was MSF, Kailahun, and they could expand up to about 100 beds, but really they were stuck with a capacity at 65. Kana in Freetown, which is staffed by a bunch of expats from Europe. Port Loco also had a small contingency being staffed by an Italian response group, and that was it, in addition to KENEMA Government Hospital. That was the medical care for the entire country. So you can imagine there was a huge amount of need and very little resource to be able to respond. By the time I left, we were helping get other groups up online. MSF started in Bo, and IFRC, which is the Red Cross, also developed a treatment center outside of KENEMA. So we were starting to be able to funnel people away from KENEMA, but when I first got there, that was the center point and really the tip of the spear for the outbreak. And it was very, very difficult for KENEMA Government Hospital to be able to meet this need. Over here are 3 of the senior people who all contracted Ebola and died before I got there. And it wasn't a theoretical concern. We had a fair number of healthcare worker infections, a fair number of healthcare worker deaths. The person that I was replacing for the WHO had just been evacuated who had Ebola as well. So it was a real deal in terms of you needed to make sure that we could get control back of KENEMA Government Hospital to be able to give care. So when I got there, there were a few of us at WHO who were sent to do an investigation to try and figure out why this illness occurred, and they were able to help me because I was slated to be the only doc. And the census was unknown, but we figured out it was about 115 or 120 once we went in. So it was a fairly overwhelming situation. Oops. And fortunately, again, it's about the team you go with. So I got there, I was the clinical lead, quote, end quote. But when you get there, you start meeting people like Rebecca Stretch, who had been there for 6 weeks. And it's really important to listen to the people who've been there for 6 weeks and who are alive and doing well, because they have a lot of pearls to teach you how to be safe. So we really had a horizontal structure where we all used whatever skill sets that we had to collaborate with the group rather than trying to create a hierarchical structure where we were just going to get in a lot of trouble. I had world's experts on viral hemorrhagic fever who were out there helping us, great infection control people. Our logistician had done a number of Ebola outbreaks with Doctors Without Borders before. So we had a group that really decided we were going to get this place safe again so that we didn't lose control of the treatment center. And of course, I got there and heard the stories of how busy the unit was and said, please show me how to stay safe, because this sounds like it's a mess right now. So obviously, to figure out how to stay safe, you need to know how Ebola is transmitted and how it's not, right? The fear and the propagation of anxiety does not help you be able to respond when it's real. It's in front of you. It's not a theoretical. So you need to be able to understand, how do I go about my day every day and stay safe and make sure I get home and make sure everyone else gets home. And at the same time, you also don't want to be cavalier, right? So EBD is obviously transmitted from infectious body fluids. So it makes a lot of sense that sick people transmit Ebola. So the idea that casual contact cannot transmit Ebola is wrong. Casual contact can, but only if you have casual contact with someone who's really sick. And that doesn't happen on airplanes or anywhere else, because really sick people aren't on airplanes. They're in bed, prostrate, and they don't move. So who are the folks? It's family members and it's healthcare workers, right? The people taking care of them and taking care of their fluids. So that's pretty much where you're going to see most of the spread happening. In addition, especially right around death, the dead bodies are incredibly infectious. So unless you have strong techniques to be able to make sure there are proper burials without exposures of folks to dead bodies, that's, you're going to continue to have spread, even if you deal with good techniques in the treatment centers or out in the community. Fomite transmission. This is controversial. It really depends on what the Ebola is in. So if Ebola is on a piece of paper and it's dry and you put it out in the sun, it's not a robust virus. It will be dead probably within an hour or two. But if Ebola is in a bunch of stool in a moist environment, it's going to hang out for a while, right? So these kind of answers of it is or isn't, there's a lot of gray area. You need to know how to protect yourself. So it can be fomite transmitted if you're not properly cleaning your treatment unit. And unfortunately, in West Africa, where we have 115 patients, many who are on the floor, and you put them in bed and they're agitated so they get off the bed, clearly fomite transmission is a huge possibility there. In Mike's center, with one patient, it's less likely to be an issue. Airborne, again, is also very controversial. It's unlikely in West Africa that that was a big way that it was transmitted, because most of the healthcare workers who were there would all be dead. So we get pretty close to folks at different points of their disease, so that we don't need to be in PPE all the time, talking to them over fences. It just doesn't look like it's spread that way. However, the caveat is we don't deliver oxygen there, and we don't do a lot of the things that we do in Western resource-rich environments. No one knows what vapotherm does to people with Ebola. No one knows what non-invasive ventilation does. Even mechanical ventilation with HEPA filters in the expiratory limb, it's unclear exactly whether or not we will be causing more transmission. You start putting OGs, NGs in, etc. So the point is, it's better to be conservative, smart, and safe rather than simply being dogmatic that it is or it isn't. We just don't know a lot of those things for resource-rich environments. This is a paper by Dan Bausch, which actually looked at fomite transmission in 2007. And the important thing is all of the different sources they looked at actually did not have PCR results. So PCR only tells you if there's RNA there. It doesn't tell you if it's infectious particle, but there wasn't even RNA that was recovered in most of these places if they're cleaned properly. So again, it makes our suspicion for fomite transmission somewhat low, but it doesn't make it zero. All right, so principles of PPE. The first thing is, in the US and in most countries resource-rich, PPE is an episodic event, right? You go in the room, you put your PPE in, and you leave. That is not true with Ebola, because the donning and doffing could be, one, pretty long, two, doffing, we know, taking off your PPE is a high-risk event. You're going to want people in for a while. When you're in for a while, you need to cover all of your surfaces, right? Because you will be backing up against things. Even though we don't think fomite's a big issue, if you get Ebola on your skin, it's not necessarily going to go through your skin unless there's a break there, but eventually as humans, we all do this. You touch things and then you touch your mouth, right? And if you're not 100% disciplined every minute of every day, there will be transmission. So the point is the PPE needs to reduce what we do as humans to put ourselves at risk. The highest level is probably appropriate early on. I've heard about people doing, it's like antibiotics. Do you do de-escalation or escalation? The problem with escalation of PPE is I could never predict when someone was about to vomit on me in West Africa. So you look at folks, you're like, does your belly hurt? And they're like, yeah, my belly hurts a little. And you give them some paracetamol, and all of a sudden they're projectile vomiting on you. You know, and some you guessed right, and some you guessed wrong. So you would be really unfortunate if you thought, oh, the person doesn't have vomiting or diarrhea yet. I'm going to go in with a lower set of PPE and then only go up in my level when they have vomiting and diarrhea. I would argue that it's pretty hard to predict. There needs to be discipline. And this is the key thing. You need to do it the same way every single time. And you need to have your game face on. Everything should be choreographed. There's no reason to examine a patient if you don't think the exam is going to help. You should only touch someone when you think it's actually going to give you information, right? So everything you do puts you at risk. The flip side is you're there to provide care. So you need to be very thoughtful about how to organize your care. If you're going to do a procedure, it shouldn't be a last-minute thought. It should be that's part of your briefing, that's what we're going to do going in, and this is how we're going to do it, right? It's all about environment of care. It's not about individuals, because you will have a problem where chaos ensues and then someone could have a break in their PPE. Your chest, your belly, your gloves, and your feet are going to be your most exposed. So given that, out in West Africa, we disinfect when we're taking off. Again, this is different than the CDC posture. So we use bleach with each step of taking off to reduce the infectious burden, because it's nearly impossible, even when you've done it 50 times, to take all your PPE off and to do it correctly every time without self-contaminating. So when in doubt, reduce the infectious burden. And of course, use science whenever available. We don't know if bleach actually ruins the gloves. We don't know if bleach aerosolizes. We don't know if Oxivir, which is H2O2, is better. So clearly science has to catch up and tell us better things, but until then, we should be doing what's worked in the past. So we went out there and we applied what everyone else was applying, which was mostly based on MSF, Doctors Without Borders experience. Why? They've been doing it for 20 years. 20 years is a pretty good track record. And fortunately, they have not had that many infections. Obviously, we now know about the infection in New York. They had a nurse who, from France who was infected. They had someone else from Europe who was infected. But overall, when you look at their healthcare worker to patient volume, they've been an incredibly safe organization. And I think we should learn a lot from that, rather than from dogma of telling us exactly how to stay safe out there, but without experience. So again, MSF has had a lot of experience. And the other thing, this is not meant as a hit for the CDC, but this is part of the conversation. Out in West Africa, they are not allowed to see patients. Especially in Sierra Leone, they were threatened with being fired if they went into the treatment units. They weren't allowed in people's homes. So we thought, I'd rather take recs from people actually, jumping with the parachute that they packed, rather than people telling me, you don't need an apron, you don't need bleach, but we're going to be outside. You let us know how it goes for you. So I think that's an important part of the conversation of there's going to be science, there's also going to be just common sense. And the common sense comes from people who've been doing it for a while. So this is just an example of kind of what we wear. This is me starting in scrubs. Obviously, I lost my luggage. That's why I had a beard. We use full set of coveralls. Then what we did is, and we're going to go over PPE later on today, I think at 11 o'clock, and then again early in the afternoon. We cut holes so that we would put our thumb through that hole so your sleeves can't fold back. And ultimately, essentially there should be no part of you that's exposed. The big issue, obviously, in West Africa is we don't have climate control. So as soon as you put your hood on, the clock starts, because it gets really, really hot in that. Rob Fowler from Canada said that they've clocked temperatures as high as 45 degrees centigrade inside the suits, and definitely that could be true. And just as important as putting it on, and probably more important, is taking it off. You'll hear a lot of people talk about observers for taking it off. We didn't do that. We had people actually commanded you what to do. So when you would come out of the treatment unit, you were tired and you were potentially at risk for making mistakes. So even if you've done the procedure day in, day out, you're not allowed to do anything without someone commanding you. So you come out, they tell you exactly where to stand, exactly how to hold your hands, they spray you, they tell you when to turn them over, how to put your arms out, and they spray you, and very disciplined. And it's not this passive observer role of a safety officer. It's someone who actively takes over safety for you. And I think that message has been lost when you translate it to the US, of they say you need to have someone who's making sure you're safe. Well, the cart's already in front of the horse if they're just watching you to be safe. They should take control of your safety. PPE for developed countries. The key thing is there's no widget that's going to protect you 100%. Yes, we have somewhat better supply chains, although we're even struggling with that right now as all hospitals are trying to buy the same stuff. But it's about discipline. So switching on to the Ebola treatment unit, the way we organize it, it's common for most units to have 2 to 3 different compartments. One is your suspect ward. Obviously, everyone who gets put in your treatment unit will not have Ebola, right? And you need to isolate those people and be able to figure out, do they have it or not? In addition, we have a treatment ward, which is for our confirmed people, and that's where you can really concentrate treatment. And we used a convalescent ward. Not every treatment unit does that. And that is for the people who are starting to get better. Get them out of your treatment unit so that you can concentrate on the sick people, so you don't have all of these people kind of walking through and diluting your time in PPE. Healthcare worker flow is key. If you go into the treatment unit and then you go back to the suspect ward, that's really not fair to the people who don't have Ebola, who are trying to get ruled out for Ebola. So it's all about, patient flow, right? Start with the lowest suspicion people. Try and decontaminate your gloves between each patient. Keep people separated, because the last thing you want is for people to come into your unit who were suspect, who had TB, and then they left with Ebola. And I can assure you that happened a number of times. One of the biggest outbreaks that was happening in Mayombo Junction was due to that happening in our unit several weeks before I got there. And I think the number was over 30 already from us sending someone home, negative PCR. They died. Family showed the certificate that their PCR was negative. They had a traditional burial, and it was off to the races. So it's very, very important not to cross-contaminate in the units. So going in, so we used buddy systems, especially after our last infection with a healthcare worker. So Henry Kiyobi Basa and I were clinical buddies. We would typically go in for 2 hours in the morning, 2 hours at night, right before it was dark. We tried to do 3 sometimes, and you're just spent. So unfortunately, there's just not that much time because of the heat and because just of human factors to be able to be in that unit for longer than that. We would do a briefing beforehand so that we were all on the same track of what the goals were, because you can get very distracted in there. You see a young kid who's dying, you may all of a sudden violate what your principles were for the goals of that particular mission going in, and then the rest of the patients will be harmed because of that. So it's very important for us to brief out before we went in and make sure we stayed on the game plan when we were in there. And we checked each other, obviously, going in. You do a full check to make sure that there's no skin exposed, that the back of your hood's not going to come up and expose the nape of your neck. And then we started in the suspect ward. So this was our suspect ward. The entrance The entrance is actually in front here. Here's the side. The ambulance would bring people in. I think you can probably see 1 or 2 people lying on the ground. They used overflow tents too, which were just really pressure cookers, very, very hot for people who were already dehydrated. So given that we were the referral facility, they would put 3 to 10 people in the back of a pickup truck that had a cab on it. That's their ambulance. No hydration for 5 or 6 hours on the road, and they would show up. Usually it would be late afternoon because of the drive during the day, and a half dozen to 10 people in a clip would be just kind of left there prostrate, and then you need to kind of figure out how do you care for them and try and start some sort of resuscitation, and that was just consistently happening. So the suspect ward, we'd go in through the front. And the key thing is we bypassed the sick people when you first got in. So we tried to organize in a way to put the right patients with our flow, and it never worked. So we just had to change our own process to make sure we didn't go right to the sickest at first, even though as intensivists we all want to do that, right? But if you do that, 1, then you will never be able to get the less sick people out of your unit, and 2, you will also probably cross-contaminate them with Ebola if they didn't have Ebola, if you take care of a few patients with Ebola and then go take care of them. So you had to have discipline to go talk to the less sick people first to try and reduce your census and get them moving before you moved on to the sicker people. And this was our high-tech way of doing census. Anything that goes into the unit can't come out of the unit in terms of electronics, so we would just write it down. And you would think this would take no time. Putting something like this together is almost your entire time in PPE, and then you're done for that morning. Because it's so hard in terms of hearing people, getting their information, getting it accurate, and then we would photograph it at the end. So the goals of the suspect ward, the key things are to get the low to medium suspect people out. Fortunately, we had the CDC lab on campus with us. They were fantastic. If you got them a sample, they would turn it around in no time. The big issue was getting them the sample from our phlebotomist. Very high suspicion people we also wanted to know because we wanted to concentrate them in a treatment unit so that we could really just pounce on them rather than having people kind of sporadically placed throughout the units to be able to care for them. And as best as you can, keep the patients separated. So the principles for the developing world. The sick contact there worked for us. The sick contact works here. Most people will have some sort of contact. The only ones who I think can't usually remember a direct contact or most healthcare workers do not recall a PPE breach. But other than that, when you're dealing with community members, they almost all either come from a community which you know is on fire with Ebola or they have a direct sick contact. Immediate identification isolation is also key. So you need to find that person immediately, you need to isolate them, and you need to keep your staff safe. In the US, we need rapid diagnostics. So the laboratory response network and the CDC element is for confirmation. It's not for rule out. In the hospitals, almost all the patients we're seeing are rule out, right? You just figure we've had now 8 patients in the US, 2 have been imported, 6,000 hospitals, 1 million beds, but yet probably all major facilities have done rule out. So rule out is where the game is, and rule out is what stops your hospital from being able to function and to do throughput. So we need rapid diagnostics, ideally at the hospital level, to be able to determine whether or not someone has Ebola or not. Isolation strategies also need to be smart. If you're going to cohort people, you can't cohort people that you're going to have cross-contamination. So just the annex, finishing up. So we did our census. Now we move on to the sick people. And pretty much in West Africa, the general treatment for sick folks is oral rehydration fluid, water. Treat for malaria if you're suspicious for it. And most people we treated using the ACT, artemisinin combination therapy. A lot of us would use antimicrobials for potential bacterial translocation with severe GI disease, but clearly that's stretching science at that point in time, but it was what you could do. And the unfortunate thing is you had about 60 to 90 seconds per patient. And the more you spent on one patient, the more you hurt other patients. So you just had to be really, really fast and decide who's going to actually benefit from my time and who won't. So then we move on to the confirmed wards. And the good thing is there's always a fair number of people who are doing pretty well, right? So this thing about Ebola, that everyone dies, has just not been our experience in West Africa. The overall case fatality rate is 70%, but when you talk to most people who've been in the ETUs, there's a fair number who just do fine. Just like the folks from Dallas, the Dallas healthcare workers. Now, they got experimental therapies, but there's also people who just, from basically getting very limited care, do fine, and we don't know why. So there's some of those folks, and we talk to them, we water them, but then you move on to the sicker people. And the way we would be able to determine the sick people is, you know, when we're dying from the heat, they're under like 2 or 3 blankets. If there are any blankets in the treatment unit, you know that that person is sick. You also start finding ward stewards, people who are getting better, who are kind of leaders of their community. And you ask them, have you seen that person walking around today? Have you seen them walking around yesterday? Because if they haven't been walking around and they were before, you know that they're getting sicker. We also ask about eating. And then even though everyone, you know, in TV always talks about the hemorrhagic complications, it's actually pretty rare to see it, frank hemorrhage in these folks. You know, the people argue that between 25 and 50% of people have some hemorrhagic complication. Most of it is premorbid state, where you may see GI bleed as they're dying. Epistaxis is a key one. If you see that, you know that person is going to get really sick. The odds ratio on death, even with the WHO summary they just put out, that's a key feature to pay attention when you see that. And gingival bleeding, again, you don't see that often as well, so if you see it, mark that person's going to get sicker. The conjunctival hemorrhage that we saw usually precede that, but you can see a fair number of people with that who still do okay. So moving on, I just want to touch on one thing before I end, which is everyone focuses on the GI, the fever, and the hemorrhage. The neurologic is the thing that really killed people in West Africa. These people get a profound encephalopathy. They're incredibly agitated. We don't know if it's from their virus's neurotropism. We don't know if it's toxic encephalopathy from their electrolyte abnormalities. Clearly could be a variety of different things. However, they are incredibly agitated. They don't stay still. And when you are trying to decide, clearly they failed oral therapy. If you're starting to use parenteral therapies, how do you do that in a safe way? Back in our units here, if worse comes to worse, you just sedate them to the point of intubating and mechanically ventilating and controlling them. There, we don't have any of that. So, you know, one of the first patients that really brought this home to me was this, you know, 14-year-old skinny kid who just had, you know, this look of sheer fear on his face. I noticed him the first day I walked in, and he just wouldn't stay still. So we thought too hard to even give him an IM injection, but we'll get to him later. We'll get to him later. I found him dead attached to a bed with rigor later on the next day. It's a profound encephalopathy that, again, when you're in limited resource areas, you're struggling with, do I use Haldol, even though I know their K is 2 and their QTC is really long? Do I do Valium, even though we know from the Guinea experience that their pH is probably incredibly low and they're barely holding on by just tachypnea to be able to balance their acid load, and if I cause respiratory depression. So ideally we wanted ketamine. There was no ketamine to be had. And then, in addition, just it's relatively short-acting. So we don't have a good strategy in West Africa on how to manage this yet. This chart, though, is from, we were asked to provide guidance on if we could do resource-rich stuff in West Africa, how would we do it? So we would do our exam, we would do some diagnostics, and then our treatment stuff. So just finishing off. Disposition. So honestly, most of our patients got very, very suboptimal care. It was very sad. It's not because people weren't trying, but I would say they were randomized to placebo almost always. But yet, more than half survived. I don't know why. I wish we could take credit for it. So there's a lot more we need to understand about the virus. I think when we compare treatment units, we should not compare CFRs because there were clearly better treatment units than ours, where their CFR was much higher. I think we should look at, in people who can't take PO, what's the mortality rate? So almost like we do in trauma, for trauma disasters, we use critical mortality. So the denominator is not diluted by the so-called walking wounded. I think we need to do the same thing here. The other thing we started to do is we started hiring people who survived to be able to organize in the units because they don't need to be in the same PPE. So just last, I've given you a lot of sadness, but there was a lot of human resilience there too. So pregnant patients unfortunately do very, very poorly. But there were some deliveries that were done in Kailahun and they were done successfully. And that's something you and your units are going to have to pay attention to because there's very likely that we're going to see an imported case with someone who needs to deliver. The second is kids. So the original teaching in Ebola is that kids don't survive. And that has not been our experience, fortunately. Very young kids actually can do poorly, but it's mostly due to strategies on how to support them when, if they were breastfeeding when their mom dies, how do you continue to support them in the unit? And this picture is the first group of Ebola kid survivors we had. So all of them had Ebola. A fair number of them were sick, and now they're done. They're all good, and they're going home. So it is worth doing this, absolutely worth doing this, because a fair number of people would do better. Thank you.
Can everyone hear me? Good. I tend to talk pretty loud, so I might have to move the microphone down a little bit. Well, my name's Michael Connor. As my presentation is getting loaded up here, I wanted to thank the organizers for inviting us. I am from Emory. We have taken care of 4 patients, and we have not nearly the breadth and depth of experience that those of you who have been to the field like Lewis has done, but we have the benefit of having been able to sort of understand things maybe at a little bit deeper level than what some of the testing limitations and such are that, that Lewis and people in West Africa have experienced. So first of all, I don't have any conflict of interest. Importantly, my wife is an ID physician at Emory, and she also does not have any conflicts of interest. And up front, I want to make sure that we acknowledge our whole team. So this is our Serious Communicable Disease Unit team. We have all volunteer ICU nurses and lab people that help us. And without their help, we could not do what we've done. This is the infectious disease leadership of our unit. They are the primary physicians in our unit. We use consulting services over here, of which I fall into 2 of these categories. And these are all the people that helped us take care of some of these patients throughout the time. I'm going to talk about clinical manifestations of severe Ebola virus disease, some pathophysiology, and then critical care management strategies focusing on safety. And I want you to be able to describe the clinical features of severe EVD, understand safety implications of critical care management in these patients. I think that's really important, okay? And develop advanced planning for delivering critical care services safely to these patients. So a couple disclaimers. We have a very limited experience of EVD in resource-rich settings, okay? In developed nations, we have a very limited experience. I'll go through these numbers for you as we go through the talk. But you have to realize that my recommendations and my thoughts and my comments here today are limited to 10, 12 patients, okay, in resource-rich areas. So we don't understand this disease fully. I'm also not going to focus on specific critical care management strategies. I think a lot of this you guys know. I don't need to tell you how to take care of patients in the ICU. Obviously, this is a critical care conference. I'm going to focus on unique critical illness management considerations in this disease, okay? Okay, first of all, How do these people present? This is a little bit old data. This isn't from the current outbreak. This is from a previous outbreak. But generally, they present with very nonspecific symptoms, okay? Diarrhea, weakness, headache. Lethargy is really, really big. I mean, you said, I mean, like that is very, very big. If you're just unbelievably fatigued, that's usually one of the first symptoms. The problem with this is that these are very non-specific symptoms, okay? And if someone tells you they just came back from, you know, some traveling, they're very difficult to distinguish this from a whole host of other travel-related illnesses, as well as just everything we can get here in the US, right? And you have to have a very low index of suspicion, especially in non-endemic areas here. And this is what some of the challenges were in Dallas when they first had the patient show up, is because not only is it just, you know, where have you been, but, you know, when someone walks in the emergency department, we're not thinking Ebola, we're thinking influenza. And it's going to be really hard when influenza hits this year, okay? It's going to be very difficult. All right, so just to clear, there's, you know, a very prodromal phase of very nonspecific symptoms. It lasts it's 1 to 3 days. Then people generally evolve into this sort of febrile gastroenteritis hepatitis phase where they can get very, very significant amounts of diarrhea. We've seen in our units up to 10 to 12 liters per day of diarrhea. They can frequently get a lot of vomiting. Obviously, they get volume depletion during this stage, a lot of electrolyte abnormalities, obviously hypokalemia, hypomagnesemia. We saw a lot of hypocalcemia also, and then metabolic acidosis for a whole host of reasons. AST and ALT go up, specifically the AST. We haven't really been able to get a lot of advanced testing. There's a lot of us that think that this proportion might be so different because of potentially rhabdo or elevated muscle injury, but we haven't been able to really test CPK reliably. And interestingly, there's not a tremendous amount of liver functional or synthetic function problems. So they don't tend to get very jaundiced. They don't tend to get you know, these bilirubin levels into the teens or 20s. And then frequently we've noticed in resource-rich settings, and you're not going to hear this in the African case series, but we see quite a lot of hypoxemia. So it's unclear if this is happening because we're being a little bit too aggressive and successful with fluid management, or if there is an underlying tropism here that is unclear, okay? But we see this pretty frequently, that patients need some oxygen support. Now, in resource-poor settings, there's a very high mortality rate. I mean, it's not, again, it's not 90%, okay? I think that's really a key, okay? But it's certainly higher than we'd like it to be, and it's probably because of inadequate access to appropriate supportive care, volume expansion. There is bleeding, not as much as people think, and obviously progressive organ failures. In resource-rich settings, we haven't seen any deaths in this gastroenteritis hepatitis phase, okay? Because we can support people through this, and not even really in a very difficult manner. There have been a subset of patients who then develop acute progressive organ failures. And this seems to be happening around days 9 through 12 of the disease, and it seems to be as the gastroenteritis and febrile phases are starting to improve. So the volume of the diarrhea is going down, the fever curve seems like it's improving, you're very excited, and then suddenly some of the patients, not all of them by any stretch of imagination, but some of them are developing progressive hypoxemia with multifocal diffuse interstitial infiltrates, respiratory distress, respiratory failure with ARDS physiology, and at the same time, they're developing a rather explosive acute kidney injury with rapid loss of small solute excretion, creatinines, BUNs increasing very rapidly, developing anuria and metabolic acidosis. They often get even more encephalopathic during all this time, obviously for many reasons, hypoxia, renal failure, but potentially also some viral stuff. So what's going on with this? Importantly, during this, we haven't seen much shock. Okay? There has been some well-publicized cases of patients who did develop significant shock, but a couple of them, including one that was just published this week in the New England Journal, developed clearly documented hospital-acquired infections that contributed to the shock. But in some of the patients, in many of the patients, one of our patients and some of the other patients have not really had much shock despite these organ failures. And then hemorrhage has been really very minimal. I think that is very well overstated. We do get some oozing, but it's really not that much of an important issue. Okay, so what's going on here? Is it direct viral invasion, or is there some sort of massive unregulated release of pro-inflammatory cytokines? We know that happens, but is that the main reason why these people are developing organ failures, or is it direct viral invasion of these organs? Is there something to do with the coagulopathy? Are they getting DICs and microvascular occlusions causing organ failures? It's a little uncertain. What I can tell you is that there seems to be a pretty significant correlation between viral load and not doing well. Okay? And this has been seen in the resource-rich areas as well, that the patients with the higher viral loads tend to be the patients who are getting the sickest. Okay? Now, some patients just don't get a very high viral load because their own body somehow limits the ability, their own immune system limits the extent of the viral load. There's some question about whether or not some of the experimental therapeutics might be limiting viral load, but nonetheless, if you have a very high viral load, pretty good sense that you're probably not going to do as well. Okay? So, severity and outcomes. So the severity is also likely related to genetic factors. So some people get a UTI, they don't get urosepsis and septic shock. Other people get UTI, they get urosepsis and shock. We haven't figured that out for bacterial infections greatly to be able to predict yet. Same thing with Ebola, we really can't predict that. And in prior outbreaks, non-survivors, at least in Africa, tended to have organ failures. Okay, so just in a couple of weeks ago, there was a very nice pathology paper that was e-published that I would highly recommend you read if you have some interest in this. They looked at 80 reported autopsy cases from around the world that were actually done in these. You got to remember, autopsies in these patients are very high risk. Okay? So it's not generally recommended. And they showed necrosis in a wide range of organs. There was very minimal amounts of inflammation. So there's very minimal amounts of host immune inflammation into these organs, but there was really wide necrosis, presumably from viral induced injuries. So the liver was most common, the GI tract with the lamina propria. This is why people get gastroenteritis and hepatitis up front, is because these organs are heavily involved. The skin has some issues. And then interestingly, the kidneys, there was widespread immunohistochemical staining of the virus within the kidney with ATN. And in the lung, there was a lot of alveolar edema and congestion. You've got to remember, all these people died, right? So they're obviously the sickest. But there was a little bit of hemorrhage. And there was clear evidence of viral replication in the alveolar macrophages with free viral particles in the alveolar spaces. Okay, so there's clear viral replication going on in the lungs and in the kidneys, which might be why some of these patients with very high infectious burdens, very high viral loads, are going on to have these organ failures. Global cases to date, we've had 9 cases in the US, 2 secondary infections, 2 primary infections, and 5 evacuated cases. There has been 1 case in the UK that I know of. There's been 3 in Spain, 2 evacuated, 1 secondary, 2 in Germany, 1 Norway. Actually, there's 1 in France also, right? I think. I forgot to put that up here. Critical illness burden. So of all of these in the West, we've had 3 patients that I know of that's mechanical ventilated, 1 who survived at Emory. And renal replacement therapy, again, that I know of so far is 3 with 1 who survived at Emory. There's 1 widely reported case in the New England Journal about a secondary bacterial gram-negative infection who did survive. We've had 4 deaths in the resource-rich areas. 2 of them were these evacuated Spanish people that was well publicized. We've had 1 death, obviously, in the US that everyone knows about, and then there was also 1 widely reported death in Germany. Okay. So there's no known Ebola-specific organ support beyond established best practices. I'm not going to debate these, but these are at least what we thought were the best practices in these patients. We wanted to avoid massive volume overload. In our patient, we wanted to do lung protective ventilation. We gave early empiric antibiotic therapy when it looked like he was getting worse because we really couldn't tell the difference between sepsis and secondary infection. And we did very early and aggressive nutrition support. Once his GI system could no longer tolerate enteral support, we switched very early to TPN, which obviously I think there is, in general critical care, some debate about. Okay, delivery of critical care requires very special consideration and planning. I don't want to tell you that you can just do this willy-nilly, okay? It does require special consideration and planning, and I want to stress My wife will be remiss if I didn't say this, that malaria co-infection has been noticed in up to 50% of patients in case series in Africa. Okay, so in any evacuated patient, you have to complete their malaria prophylaxis. And it's highly recommended that you check 2 to 3 rapid malaria screens if you can, just to make sure that if they get sick days 9 to 10 back in your unit, it's not because of malaria that's making them sick. Okay? The only proven treatment is advanced supportive care. We have no FDA-approved agents. There's various emergency investigative agents that are under consideration and release as possible. All US and Europe cases have received several investigational agents in uncontrolled fashion with unclear results. Okay? So we've sort of thrown the kitchen sink at everybody, and so it's very hard to know on the people who are surviving and doing well what it was that's making them better. These are the various experimental therapies you should know about. If you get a case, you will be hearing from the CDC and others, including me, about all of these potential things. Convalescent plasma. This hyperimmune IgG, this is not currently available. ZMapp, which is well publicized. Tecmira, which has been well publicized. Increasingly well publicized is brincidofovir, which is a variant of cidofovir, which inhibits viral DNA and RNA polymerases. It's easily, readily available because it's already undergone phase 3 trials for CMV and is basically almost approved, I think, for CMV treatment or about to be approved, so it's easily produced. Has some good potential early thought that this might be beneficial. Sarepta and a few other agents, okay? We're not going to go through these in great depth. Okay, so how do you manage an EVD patient? Safety is paramount. Patient safety, healthcare worker safety, community safety. This is very, very, very important, okay? And how we define success, I think, has to change. Because normally, we don't have much concern about ourselves when we're caring for critically ill patients, okay? We don't eat, we don't sleep, you know, we do what we need to do. EVD patient survival, to me, does not equal successful treatment, okay? I hate to say this, but it's true that successful treatment is a good patient outcome and no one else contracts the disease from that patient. Healthcare workers, contacts, etc. And I will step a little bit out on a limb ethically and say that it might be that healthcare worker safety supersedes patient outcome, okay? Because ultimately, we have to care for potentially other patients, and if we can't do that, then that's a problem. Critical care management and life support interventions can be delivered safely in EVD. I've heard rumors out there that people say, we can't do this, we shouldn't do this, if they get this sick, we just need to let them die. Okay? And I would argue that that's not the case, but it does require very careful planning and consideration. You have to think about this. You can't rush into it. Even if you plan ahead of time before you even get a patient, once you get the patient, you still have to plan and think about the interventions that you're going to do. Flexibility is key. Less than a full complement of labs. You don't have everything at your disposal. Those of us that work in the ICU, we're always so excited. We got all these bells and whistles. We can do all this other sort of stuff. You don't have all of that. Okay? Improvise. You have to be able to improvise. Okay, you got to be able to say, okay, I don't have this. How am I gonna make do with what I've got? And then we need to consider all aspects of any intervention prior to doing it. Okay, how is this going to impact the patient? How is it going to impact the other stuff? This is what you're working in. This is Dr. Kraft. She's smiling here, but a lot of times we're not smiling because we're very hot and stuff inside these. It's not easy to work in this. I think Lewis talked about that. I think it's also, I don't think we're giving enough credit to how scary this must be for the patients. You got a whole group of people coming in like this. They look like aliens, right? I mean, this has got to be frightening for the patients as well. You're working in very difficult conditions. There's barrier to normal patient care and interaction, like just even when you have somebody on C. diff precautions, right? You don't feel like you have quite the same connection to them. Imagine wearing all of this. It's very slow to put this on. How long does it take on average for you to don?
It's about 15 minutes.
15 minutes, okay? I think that's probably on average what it takes. And it really requires a buddy. I like what you said. I thought that was great, that it's the job of the buddy to ensure your safety, not to monitor your safety. I like that. So you do not need to practice in this sort of environment, but this is what our facility looks like. We have an anteroom right here where we can do all sorts of prep work. We have an area in here for showering after the staff comes out. Many places have a separate room that they go in and then another room where they come out over here. I like that idea too. And we have 2 then isolation units over here. You do not need to have this sort of setup to take care of the patients. I want to stress that. So when we're going to do critical care safely, I think there's 3 things. Patient safety, healthcare worker safety, and community safety. So let's go through each one of these. Patient safety. I want to stress that in my view, the biocontainment isolation is risky to the patient. Okay? We have to remember that because we cannot intervene quickly in an emergency situation. Okay? You might have a very experienced and diverse staff, but we have a one-to-one nurse in the room with the patient at all times. So she or he is in PPE. They're in full PPE. They go in for 2, 3, 4. Our PPE has circulating air, so we can last a little bit longer inside there. And they're in there, and they have to rotate out frequently, but they're there by themselves. So if you're providing critical care and something terrible happens, it's very risky to the patient because no one else can get in very quickly. Okay, so you have to plan ahead. You have to realize that. So from a patient safety standpoint, we as best as we could tried to think of backup plans at all times. We planned for problems, okay? We wanted to make sure that there was emergency airway supplies already available if it became a difficult intubation because we couldn't rush to get that stuff. We always had a self-extubation plan. Normally when someone self-extubates, you run right back in, right? And you just re-intubate them. You can't really do that. So we had to make sure there was bag malvask and suction there. We had the re-intubation meds and all the supplies immediately available. We had some debate about, what happens if the patient is sort of struggling, they're confused, they're not breathing very well, they're agitated, they're moving all over the place, we're waiting for people to go back in, but we knew that they were relatively easy to bag ahead of time. Should we just sedate and paralyze it with the nurse in the room by herself so that she can sort of bag the patient safely? Normally we would never do that, right, without somebody directly to control the airway. But we had some thoughts about that, and we're not sure exactly how to handle that. Do you want to have a non-invasive ventilator as a backup in the room? I'm not sure. These are just questions. We always had pressors immediately available and push meds. We had the nurses knew what they needed to do for emergency disconnect of renal replacement therapy, clamps and stuff. And you have to remember that he or she is working alone. Okay, support is not immediately available. I've said 5 to 10 minutes. That would be shocking, but probably more like 10 to 15 minutes before the cavalry can arrive. Okay. Personal protective equipment. PPE is effective, but it cannot be trusted that it just, you put on PPE and you won't get anything. You have to do it properly. Doffing is very important. It can increase risk as well because the doffing is risky. Buddy system, we already talked about that a lot, so I'm going to skip over that. Okay, so healthcare worker safety. Minimize potential exposures. Okay, I can't stress this enough. Contain all infected fluids. We use a bowel management system, even in a awake patient. The moment they start having copious diarrhea, they get a bowel management system because then at least we can control the stool. The stool is highly infectious. We don't have it all over the floor and that sort of stuff. We batched our blood draws. We put in a CVL or a PICC line very early because we didn't want to have to be dealing with needles and drawing blood. We could draw blood directly from the central line. We recognize that there's obviously a risk to insertion of lines, but we thought the risk-benefit ratio, at least for healthcare worker safety, favored the use of central lines. We use needleless and contained blood draws as much as possible, no reflux caps. And then we frequently clean the environment, the surfaces, the floor, etc. The nurse and the clinician in the room does all the cleaning. We do not allow any unnecessary staff to go in the room. We do not allow environmental services into the room. The nurses and the clinicians clean the rooms. Not every physician or consultant must or should examine the patient every day. This is heresy, right? If you've got one of your colleagues who's examined the patient and can tell you what the lung sounds like, trust them, be done with it, okay? Ask the nurse, push on the belly, does it seem firm? If it doesn't, okay, that sort of stuff. And we batched our procedure. So if we went in to intubate, we said, okay, we're intubating central line, and we knew we needed dialysis at that point. We put the dialysis line in all at the same time so that we didn't have to have multiple points of entry to do procedures. Healthcare worker safety, part of this is labs. I want to make it clear that there's no mandate that requires labs to be processed in a biosafety lab. But the reality check is that if you have a lab specimen that spills in the main lab, it's going to be a complete disaster in your hospital for hours, okay, or days, and then everyone will quit, and then you have a problem for longer than that. And really, the technologists, if they know that this is an Ebola patient, they're going to freak out and not run this. So the point is that most centers have established a dedicated lab space in or near the isolation unit with dedicated point-of-care testing, and these are some common solutions. I would refer you back to that paper. Staffing models, all I would say is that you have to remember you need frequent nurse rotations, okay, much more so. You have to have a buddy system. Who's going to be the primary clinician in the room? We have it as the ID team, but that's just because our unit has been set up that way. I'm not necessarily sure that that's always the best approach, because honestly, the critical care person can do all the procedures and everything like that too. So you have one, if the patient is examined and needs a procedure and needs other stuff, now you only had one person that's coming in. There's not a lot of findings that the ID person needs to necessarily examine the patient for. So I think that's really a matter of debate. Fatigue, I can't stress this enough. It is very tiring. Even if you're not in the room all the time, okay? Because we had our ID team in the room and we were trying to minimize interactions with our critically ill patient, I very rarely actually went in the room, all right? But it was still incredibly fatiguing caring for this patient, dealing with this, thinking about all this other stuff that we had to do, all this safety aspects, how are we going to do all this? All of that was very fatiguing as well. And fatigue impairs concentration and focus and increases the errors of PPE and the such. So please remember that. You need to have a post-exposure plan in case there's a failure of PPE. This is not a post-exposure plan to take care of everyone who went into the room in appropriate PPE. This is the needle stick. This is the my PPE failed and I got stool all over me plan. Okay? You should quarantine versus isolating and monitoring them. There's various post-exposure prophylaxis trials going on right now for both Tecmira, brincidofovir, as well as VSV and the adenovirus Ebola vaccines. Community safety. So the isolation environment, biocontainment room, ante-room for donning, maybe a separate room for doffing we make everyone shower after they've doffed. Okay? Medical waste disposal. These regulations really vary, so I'm not going to get into this. Okay? Because what one county or one state wants you to do with the waste is very different from the other counties and state, and oftentimes are very different than what the CDC or other people are recommending. So we're just going to leave it at that. You have to think about it. And then you don't want any potentially contaminating materials leaving the biocontainment area. And so this is what we did. I'm going to go through an example for our patient that was critically ill. Okay? Then hopefully we will have a couple of seconds for time. We had an evacuated healthcare worker from West Africa, had a very high viral load, got these symptoms. About 8 days after admission, developed respiratory distress, progressive hypoxemia, acute kidney injury. We intubated, mechanically ventilated, and put the patient on dialysis. Okay? CVL was inserted very early in the right IJ. We expected an easy airway because the patient looked like there was going to be no issues, but we planned for complications, and for that reason we asked anesthesia to intubate the patient because we didn't want to get into a situation where it was difficult. All reintubation supplies we kept in the room at all times. Sedatives were ordered and always ready in the room so that the moment the patient had any, because we really didn't want a self-extubation, so even if we were trying to minimize sedation, we had it immediately available. Vasopressors were available in the room as well. We had a multifunction ultrasound that was in the room so that we could do various diagnostic tests, but also use it for lines and procedures, bedside echoes. Portable plain films was available. I will tell you, it was like not so easy, but we were able to jerry-rig the machine outside the room and sort of swing the arm in. And, you know, one day I would get the left lung, the next day I would get the right lung on x-ray, you know. So, again, you have to sort of improvise. And then all life support equipment remained quarantined in the room until we terminally disinfected the room after the patient discharged, vent, CRT, ultrasound machine, pumps, etc. We used vaporized hydrogen peroxide. A specialty contractor comes in, seals up the room, basically like fogs it like you do if you're to kind of get rid of fleas. And then there's a rest period for all the equipment, and then we will eventually return this to general circulation. You do not need to throw away your dialysis machine or your ventilators after this, which is another rumor that I've heard along the way as well. So we did renal replacement therapy. We used CRRT because we said that our ICU nurses could do this. We didn't need a specialty dialysis nurse to come in. We used a single device because then we could also transition to prolonged intermittent renal replacement therapy, again, avoiding having to bring in the dialysis nurse with a big dialysis machine. Single device could be used the entire time. We also had longer filter life with this, so we could decrease the amount of waste we were developing, and it generates less spent effluent waste. We minimized the circuit exchanges by, again, using CRRT. We also used regional citrate anticoagulation so that we could maximize our circuit life as much as possible. And we actually had to redo our whole line strategy because we wanted to use the right IJ because we know that for dialysis, that's very clearly the best line to use for CRRT. So we deeply positioned the right IJ and put in a new central line on the other side. And we got good blood flow with that, and we had great filter life. The dialysis effluent, I just want to say that the virus RNA and the virus and the RNA are way too big to fit through the membrane of a dialysis membrane, so the effluent shouldn't be infectious, and we've actually had, we tested our effluent for Ebola virus RNA by PCR, and it was definitively negative on several occasions. However, you cannot exclude that there would be not a secondary contamination of the effluent, but if the effluent spills all over the floor, the nurses should be reassured that it's not like spilling stool or blood all over the floor. The effluent shouldn't be infectious, but because we couldn't exclude a secondary infection, we disposed of it in the same manner. I will call your attention to the CDC acute dialysis and EVD guidelines that were just published this week. This is largely based on a manuscript that we have in press and our experience. We co-worked this with them on developing this, so call us if you have questions. Okay, so our patient survived, got better. We were very thrilled by that and has been discharged, in case anybody was wondering, and they are doing great. Now, there are some important things that we thought about up front. We said we are not going to provide any exceedingly high-risk interventions like ECMO, okay? Because you got blood and infected material all over the place. We said this is not a good idea. I also think that we had to have a plan up front about what was going to be some of our other limitations of care, okay? And I don't want to say this as policy, but I told the family up front that I don't think it's appropriate to do CPR ACLS. And our patient's family was very understanding of that. And I think that's because we have a significant healthcare worker safety issue here. If this patient codes, okay, aside from the fact that you've got one nurse doing CPR and taking care of the patient, pushing meds, one person CPR in an ICU is never going to end well, right? People are going to be very likely to rush through putting on PPE, okay? And they could make mistakes with that. Then they're also going to have healthcare workers, many healthcare workers in the room for a code. How many times? I mean, it's like the whole world shows up. You have high risk for body fluid exposures, things going everywhere. You might get a needle stick injury. I just didn't think that it was appropriate. And I think that a lot of other people probably feel the same about that. Now, if let's say we have a huge outbreak, okay, and we've got 12 patients in a single ward where they all have Ebola, and we all go in, and there's like 10 people working for a shift in PPE, and we're all in there, we're just moving from one patient to another, and somebody codes, well, now you've got a bunch of people in the room, in this environment already. It might be that it could be safely done. So I don't want to say for sure, but in our situation, it was not appropriate. Okay, we learned some important lessons. We decided that we will preserve the right IJ. So we are now using PICs or left IJs because I didn't want to have to do separate procedures, multiple procedures. Expect them to need dialysis till they get sick, so that's why we're going to preserve the right IJ. We have migrated to exclusive balanced crystalloids as primary solutions for volume resuscitation. I think that can be debated, but I'm a believer that they're associated with less severe AKI, less dialysis needs, maybe less transfusions, and maybe a lower mortality rate. And we avoided marked hypervolemia, okay? And need to determine if and how we would offer emergent surgical services. We haven't figured that out yet. What if they perfed or they had an appendicitis? We haven't quite figured out what we're going to do for that yet, I will admit that. Okay, so conclusions. Critical illness, it does occur. Supportive care remains the only treatment. The principal issue in caring for these patients is safety, and it can be done safely, and critical care and life support can be provided safely with planning and vigilance. Any questions? You can call me or email me anytime if you have questions. I see all the cameras going up.
Thank you very much, Dr. Conner and Dr. Rubinson, for excellent presentation. I come from a resource-poor setting, and I really appreciate what you guys are doing. I think you're really moving forward the science and the practice of Ebola care, and I think generally healthcare for these kind of settings. We have time for probably 2 questions. We have a presentation starting very shortly next door. Anybody on this side wants to volunteer a question really quick?
The clinicians who took care of the patients you had at Emory, were they limited in their contacts with other patients outside the treatment unit? I mean, did you quarantine yourself for a period?
I'm sorry. The question is what was our process for taking care of other patients? At Emory, we trust our PPE and biocontainment strategies, so we have not instituted a limitation in care of other patients. So that's the best I can say. I know that there's a lot of questions and politics about this. Some of that is not based on science, okay? Some of that's based more on fear. I will tell you that in the U.S., we've had 9 cases with 1 death. Okay, so I think the fear of mortality is probably much higher than the reality in this country, and so I think that's driving a lot of the things that you're hearing in the media for some of these decisions.
Thank you.
2 quick questions. You mentioned a negative PCR in a West Africa patient that went on to get Ebola. So again, the question of how long the PCR takes to turn positive.
So during an incubation period, it will not be positive. Once symptoms start, you're right at the threshold of detection. So the usual teaching is up to 72 hours of symptoms. Then at that point, you absolutely, if you have a negative PCR, you can rule it out. And that's the dilemma people aren't talking about here. So if you have someone on day 1 who has a negative PCR, that does not rule out disease.
And the other question is, it seems if you look at the last couple of Ebola outbreaks, maybe this is more virulent now than it was 10, 15, 20 years ago. And the question is, have you seen any repeat, what looks like a repeat infection because the virus has changed?
So in terms of strains, so obviously there are 5 different types, right? And they have different virulence. For Zaire, actually, I would put this as a lower virulence than Zaire normally is. Zaire is usually near 90%, but it obviously depends what kind of care you're getting. Right now, the assumption is if you get Zaire, you will not get it again, at least in short period, right? There may be some waning immunity over a period of time, but the Israelis have looked at this, and at least it looks like neutralizing antibody may be present even 10 years after. I think it was 12 years that they looked at. So right now, we are under the assumption that you're not going to get it again. The virus may be changing, and we don't know, because in different countries, there's different host immunity, there's different nutrition status, there's different supportive care, and the virus may be evolving to be able to be in humans longer, which means the virulence will go down, but we don't know if that's the case versus all the other factors. So clearly at some of our sites, we're seeing CFRs under 50%, while others are 70, 80%, and we don't understand why, to be perfectly honest.
And just so the other reason we don't know if people have been co-infected is we had to remember the geography. West Africa, this is the first time they've ever had Ebola, and they are thousands of miles away from where the other Ebola outbreaks are, and those areas are not experiencing any outbreaks. So repeat infections, we don't know from this outbreak right now.
But in terms of using survivors, right now we think that's a very reasonable strategy. If people get beyond the emotional issues of that they had a life-threatening illness and can provide care, we started hiring people both to take care of orphans as well as to work in our treatment units, and I think you're going to see that more and more. Right now there's just under, I think, 4,000 survivors in the 3 countries, so it's a fair workforce, again, depending on if people want to step up to that to be able to utilize. Theoretically, they don't require the same PPE. They really just need to avoid other bloodborne pathogens. So it's a huge struggle to have someone in the unit 24 hours a day. As Michael even alluded, for one patient, it's much harder in hot environments. So if you can have someone who essentially lives in your unit for a week to 2 weeks and make sure that people get rehydrated when they get sicker, that someone shoots the flare up so that you can find them, I think it's probably the only strategy to make the treatment units in West Africa actually operate better.
But make sure that they don't bring Ebola out of the unit when they leave. So they don't need the same PPE necessarily.
But they don't leave for a week or two, right? That's the whole point. So anytime someone goes in and out, there's an enormous process of controlling who can come in and out and how to do so.
Great. Thank you all very much. I think we'll terminate questions.